what can a state do, I've talked about this, to address the squeeze on the front end in terms of hitting eligibility for beneficiaries and the back end in terms of limiting program funding? I can really only do two things as far as I know. My colleagues will correct me if I'm wrong. One is they can reduce the amount that they pay providers for the care that they provide, or they can kick beneficiaries off the rolls and categories. I think that's all they can do. So that's limited. And the state doesn't want to kick beneficiaries off the rolls, and so what they'll do is they'll reduce the rates that they pay to providers. The problem is New Hampshire is notoriously one of the lowest Medicaid reimbursers in the country. Dartmouth Health is 40 cents on the dollar. So over the last several years, each year, Dartmouth has provided, let's call it $300 million in cost of care for Medicaid beneficiaries, for which we've received $100 million. So what's the delta? The delta is $200 million. What happens when that happens? What are providers supposed to do in that situation? I don't want to go into financing. There is some help from the federal government for uncompensated care, right, and undercompensated care. So we get some relief to mitigate the amount of uncompensated care we provide. That $200 million underpayment from Medicaid, plus the people for whom we provide charity care, which is either free or reduced based upon their income levels. Healthcare providers have, I think, three options too in terms of what they can do when they're faced with that type of hole. One is to cost shift, which is to charge those commercial payers, this is why I talked about insurance at the beginning, more for services than they get under Medicaid or Medicare. So your Cigna plan, all of a sudden, we're going to negotiate with Cigna, we're going to try and negotiate with Cigna for more money for the same services that we get paid less money from a different payer on. That's one option. The other is you can reduce costs, right? So you can let people go, or you can stop providing services. I mean, so that's another option. No provider wants to do that. And so the third option is you could absorb those costs to some degree. And then there's a question of how much can you absorb those costs. Usually it's some of all three, right? You're doing some of all three of those cost-saving, revenue-generating, absorption philosophies. And I believe that Dartmouth Health, it's huge, right? It's big. It has lots of members in it. We're going to survive the cut, because you're going to go from getting paid 40 cents on the dollar to getting paid 35 cents on the dollar in Medicaid in New Hampshire. West Central Behavioral Health is in a different boat, right? Because they have 90% of the people who come in their doors receive Medicaid. And so what do they? You were incredibly optimistic with respect to we're going to raise funds, alternative funds, to plug those holes. That is one of the choices, and maybe the only choice that they have. Otherwise, you limit services. Hospitals, too, provide care to all comers, right? There's a federal law that requires hospitals to accept everybody who comes to the emergency department. We don't want to turn people away. But what does this do to access? It constricts access, right? Because you're either, say you're waiting, I don't know, a month for a primary care visit today. And then Dartmouth has to make a decision about, do we expand our primary care population, our provider base, or not? Well, we can't right now because we're going to take a hit, and so you're going to wait 2 months for a primary care visit, right? Because you're not meeting the demand because you have fewer resources to do so. Or someone doesn't answer the phone when you call them to get your medical record as quickly as you'd like, or don't call you back as quickly as you'd like. None of those things are good options, but it's part of how you navigate being squeezed by the federal government on the front end and the back end.